As Gene mentioned, from Arkansas. We live in Fayetteville. This is what our home, the different seasons, usually looks like. This is what it looks like this week. So we were really happy to come to Charleston and escape that. So this is my crew. It is not the Von Tropps, though that picture was actually taken at the Von Trapp Lodge in Vermont. This is my team. This is my son, Miles. On the far left, our daughter, Macy, my wife, Tara Renee, who fortunately joined us this weekend, and myself in the ugliest Christmas jackets we could possibly find. And these are the people that I enjoy spending the most time with. Which brings us to our subject today. How is your time valued? And there are certainly a number of lenses that we can look through to do this. Some view this purely from economic models, one of which would be the cost-based method, and basically, how much are you willing to pay someone to do the work that you do? The other would be like a market rate method. If you worked somewhere else, what would you expect to earn if they hired you for exactly the same job? Everyone here has probably used the third model, which is the expected value method. We use that all through our training, and that's what do we feel like the value of the time we're spending now will be worth in the future. Some view time much less mathematically and in the terms of happiness and meaning, and David Mellon referred to this yesterday when he was on the panel. And you know, it's taking these factors that are hard to quantify, at least collectively, happiness and meaning, and what does a task mean? How much does it take and add to our happiness down the road? Context certainly matters. And then some will put this in a framework of our potential work years or our healthy years, or how much time do we have to spend with our children or our loved ones. Certainly, that's really hard to quantify, and certainly an estimate. We don't know how many healthy years we'll have. We don't know how much time we'll have to spend with our loved ones, etc. But for the next portion, you know, we have to take and weigh in our personal values. We have to weigh in opportunity costs, and those are very individual, as are things such as how we define our work. How do we define distractions, our personal joy, our worth? But for a little while, we're going to get away from some of the more philosophical definitions of time, and we're going to look at it from CMS, which is not philosophical. And we're going to actually blow apart the black box that is our actual CPT valuation. This is how the sausage is made from the inside. Just by show of hands, how many people know actually how the CPT codes are valued? A couple, right? So it's not exciting, but it is something that's important to know. And I'll lay a foundation for this. And back in 1992, as many of you know, the physician payment system was transitioned to this resource-based relative value scale. And basically, it's where the payments for the services we provide are determined by the resource costs that provide them. And there have been a number of speakers that have referred to this and said, do you know actually what it, Dr. DrManning made a comment, do you know actually what it costs to take and see a patient or to perform a specific procedure? Well, Medicare and the AMA, they do try to quantify this literally down to each Kleenex, glove, piece of gauze, instrument, time in the chair, minute of staff time. In order to take and identify what these resource costs are, put together the RUC committee. And we'll talk a little bit more about that in detail. And this process, in conjunction with CPT, which actually CPT defines a specific service, right? Down to the commas and the EGs and IEs and all these things. And then the RUC takes that and develops value recommendations for these new revised and misvalued codes. I'm going to reiterate, those are recommendations, as Dr. DrManning will tell you. In the past, when this process first started, over 90% of the recommendations that came out of the RUC were adopted by CMS. Now it's closer to 60%. So even though they'll go through the whole process and they have our input, they don't always take it, unfortunately. So this is how it's divided, right? So you have three major components. About 4% is designated for our liability insurance. Practice expense is about 45%. And again, practice expense is everything from your equipment, instruments, your disposable medical supplies, the time that your MA, RN, front desk staff down to the minute spend on a particular service, okay? And then there's the physician work, and that's where actually you have some input, and that's about 51%. I'll talk about later how this interface is actually how we can really create some efficiencies in our practice. So the physician work component, what does it take into account? Time, which is where you actually have input, the surveys that come out. There's the technical skill and physical effort, you know. Clearly it's a lot more difficult to repair a pediatric heart defect than it is to do a biopsy or read a chest x-ray, but you know, don't ask the dermatologist or radiologist, they'll disagree. And then the mental effort and judgment that's required, and then the stress on us due to the potential risk to the patient. In ENT, many of our procedures, actually we get paid a little bit higher than many specialties because they take into account this, because we're working along the skull base, et cetera, with cranial nerves on and on. So that's an argument that we frequently use and is sometimes accepted. So what happens when you get these RVUs? We all know that these are combined by a conversion factor, and then this is multiplied times your geographic price cost index, and it looks like this. So we have the work RVU, and that's 51%. That's the minutes you spend, the risk, the effort it takes, times the GPCI. Then there's the practice expense, times the same, small portion for malpractice. And then we take all of those and combine for the conversion factor. People, I don't think always realize why the conversion factor has gone down or stays the same, and it's because of budget neutrality, right? So what happened some time ago, actually back during the Obama administration, they said it has to be budget neutral. So we would think it would be favorable for all the E&M codes to go up in RVU, right? What's a zero-sum game? And that's why it's so competitive at the level of the RUC. The size of the pie is fixed. It's just how do you slice it up, right? So if we increase the total RVUs out there, including for E&M codes, for CPT codes you add in for new technology, someone overpays for a particular procedure that's being reimbursed, then you just have to lower the conversion factor because the total amount of money that we're going to get paid from Medicare stays exactly the same. So the RUC committee that makes these recommendations, there's 31 members, 28 vote. They're from the major specialties. We have a couple of panelists from our specialty that sit at the RUC table while we're sitting there, and you have the RUC hat on. You have to be independent. You have to recuse yourself if there is any code that is pertinent to your specialty that your specialty is weighed in on. And when you're at the table, they're not advocates for your particular specialty, right? And then we have some advisors. We have two from our academy that we kind of all get together in advance, and you put together the data on whatever code's being brought forward, and then you present that to the panel. There's a voting process. One of the things that people need to realize, I think, and they say, well, I'm getting underpaid for a particular case. Well, there are a couple themes at the RUC. One is it's for the most common occurrence of this procedure. So if most of the time it takes you an hour to do something, but occasionally you get a very difficult patient and it takes 2 hours, they're going to take whatever it happens the majority of the time. The other is they almost always, I would say 95% of the time probably, take the 25th percentile for whatever is submitted. Okay, so whatever time the surveys come in, people will take, and they will, at the RUC table, it's very uncommon when they're taking and making this relative to the existing code set. So this is the process. These are the people on the RUC team. Brad Marple down at UT Southwestern, myself, and then we have Pete Manis that's up in New Haven, and we have Ari Wirtschafter that's with the big Florida ENT group. Great team to work with. These folks work really hard on our behalf. Especially Pete's been doing this a long time, and at the RUC table he kind of has a the reputation of having the golden tongue. He's the only one that can talk them into occasionally going beyond that 25th percentile. So kudos to Pete and the hard work that he does literally on a weekly basis for this. So this is the entire process, and I'll break it down in a little more detail so you can understand, one, how it affects your particular practice, and two, where you can participate. And then we'll take that framework and bring it into the payment cycle that's not related to Medicare. And I'll give you a story of how I've taken and you can take and you can move that needle. So where do the codes come from? As I mentioned, there's this CPT panel as well. You're all familiar with the CPT book. It has the descriptions of what we do in particular. So there's those that are for new codes, and they have to meet a certain level of evidence. People always ask this, why can't we get a code for X, Y, or Z? Well, there are a couple of things that have to happen. One, it has to be in wide usage across the country and relatively stable. There has to be literature that's from multiple institutions. And this is something actually we ran into initially with the eustachian tube balloons before we were able to get a code for it, is you brought it to the panel and they're like, well, that's great, but almost all the papers are coming out of the same couple of places, right? And they were working hard on this, but that actually is a detriment. And then there are screens that CMS uses, so that's out of the CPT panel, but CMS uses screens. And this happened, for example, when started bundling together ethmoidectomy and sphenoidectomy, or frontal sinusotomy and ethmoidectomy. And so one of the screens is if codes are, if they're reported more than 75% of the time together. That's one. One is if there's a change of site of service, which has implications as we're moving from an ASC to the office. So that can cause these to trigger a revaluation. And then some if there's a change in specialty, the dominant specialty. And an example of this would be with thyroid codes, as we're now the dominant specialty, et cetera. And then there's something else that's really important that I think people don't understand the risk of. And this actually just happened with our BAHA codes. And Dr. Danny mentioned yesterday they went down about 50%. Well, there are a number of reasons for that, and you're like, well, why would you bring it up in the first place? Well, if people bring it forward, let's say they have a transcutaneous magnetic BAHA, right, versus the percutaneous, and they'll want a new code for that. They're like, well, it takes longer. Well, that makes sense. Or they'll say, hey, we have a thyroid ablative procedure, and we want to put that in the thyroid code set so we can get paid for doing this. Well, there's risk in doing that because it will open up the entire code set. And if you have really good valuations that were based on surveys, deliberations, the whole process in the past, if you open it up for a single code in a set, you put everybody at risk. So that's something that really you have to take into account, okay? And so these codes are set forth a few days later, literally days after they come out of the CPT panel. Then the advisory committees, which is our advisors, Pete and Ari, and we'll take and sit down with them, as well as with the team from the academy who works really hard. Maura Farrell, again, she's really engaged in that. Jenna Minton, who used to be at the academy for a long time, but now she has her own nonprofit in Michigan, still works hard as a consultant with us on this process. But we'll take and say, what are we interested in? Well, obviously, if it's an orthopedic code or OB/GYN code, we're not interested because you get the whole list. And then we could say, well, we're really interested. We do this all the time. Or it might be something where audiology does 99% of it, but since we employ audiologists, we'll weigh in. So we have several options there. So we express our level of interest. And our level of interest is we're going to survey, and we're going to help value, we're going to present the table. Number two is, hey, you know, we do this some, but it's mostly neurosurgery. So we'll weigh in, but they're going to take the lead. The third is we're disinterested, frankly. It has nothing to do with our specialty. Or the fourth would be, well, we don't even think that this needs to be revalued by anything. It really can be a change at the CPT level. An example would be if you need a new definition for something. If things have been very different over the past several years in the way they're performed as opposed to the past, and you can just take and you can change descriptors and things and keep it off the table. Then the surveys go out, and that's where you weigh in, but unfortunately most people don't. We had to bring the BAHA codes to our membership 3 times. It's a ton of work, which people are happy to do, but even the last time, and granted there could have been some survey fatigue, it was really hard to just get the required 30 people to give us their times. I mean, you all's group alone, if you'd respond to the survey, could literally define the times that we get paid for procedures. It's literally 30 people. So there's real opportunity, and there's real opportunity, for your private practice groups. When you weigh in, it's not like, oh my gosh, they're just taking into account what me amongst thousands of people. No, I mean, a 10,000 otolaryngologist, you have 30. I mean, you're going to define that time. As you saw, the physician work time is actually the biggest component. So it's an opportunity. So when you get the things, I know we're all super busy, but consider taking the 30 minutes, which 30 minutes is valuable, but it's 30 minutes where you're actually writing the policy if you look at it that way, because it's those actual numbers that you set the relativity. And they're not going to give us credit for doing something that someone says, they literally said it took them 5 minutes to put in a BAHA, which is really fast. I can't imagine actually people even getting draped in 5 minutes, but that's what they said. And so those are all weighed in. And so when people want to pat themselves on the back when they fill these things out and say, I'm super fast, that's probably not the average patient. But in any event, those actual numbers are statistically what's weighed in. And then the RUC goes and they make a recommendation, and it's forwarded to CMS. And at the end of the day, CMS takes and they put this in the proposed rule as a change to the Federal Registry. And then we weigh in, and we get our final rule, and the next January, that's what you get paid. So that's the whole process, right? I'm going to focus again here, right, in the physician and practice expense portion. So I had to think a lot about efficiency in our practice, and in a few minutes I'll explain why. But when you can shift this practice expense, which means staff minutes doing work that you could be doing that's very appropriate, right? You're going to be much more efficient and probably happier. I don't know too many of us that would rather be doing administrative work or clerical work than we would be actually taking care of patients. I think all of us in the room find the most meaningful parts of our jobs to be direct patient care, right? So, really appreciate the story that AJ told. Yes, it was a great way to give a presentation. So this is one of my partners, Felicia Johnson. She's fantastic. She's very hardworking. She's talented, bright. She is married to another otolaryngologist, James Ragland. There are actually a couple people in the room that were in residency with him. He went by Jimmy at the time. Great guy. They have a son, and their son's name is Evan. Evan's a musician. So Felicia's working really hard, and Evan's growing up, and just her work ethic and her care for patients, she's super dedicated. She wants to spend more time with Evan, right? She wants to go and take Evan to his music things and travel to do this. Myself, in 2017, was super busy. Our practice was booming, and as many of you, I'm the managing partner of a mid-sized single specialty practice with multiple locations, and I was spending all my free time, it seemed like, doing that. I'd just taken the role leading medical staff for a big hospital system, or big for the region. There were 5 hospitals, and so I was leading those from a medical staff standpoint, and that required a lot of work. And then there were some other things in 2017 I just wanted to get done. I wanted to get more involved in health policy work and stuff with the academy, and made a lot of friends doing so, frankly, which has been great. Had some life experiences, and that I still wanted to do. And for me, building relationships is super important. And those life experiences with those people, those are the most meaningful parts of my life. So, no alternative payment model. What we came up with was an alternative practice model, right? So what Felicia and I decided to do, and we gave some value propositions to our other partners, was to essentially share one physician's fixed expenses, and I'll explain how we do that, by alternating weeks. Sometimes we alternate 2 weeks at a time. It depends on Evan's school schedule, frankly. And we wanted to protect and maximize the time we're there. So I work clinically about 26 weeks a year. During that time, I do nothing else. There's no vacation times. There's no half days off. I'm maximizing my time in the OR. I have one late day in the OR because I like to do a lot of head neck reconstruction. not microvascular, but all the other stuff. And most of my practice is adult practice. And so that being the case, I need a fair amount of OR time to get those things done, and a lot of the adults are fine with me doing things later in the day. But in any event, I wanted to protect that time and also maximize that, and Felicia wanted to do the same. So what we have to do is you got to move this. There's a lot of physician work that really doesn't require a physician to get there, right? And it kind of brings back to this cost-based method. How much was I willing to pay someone to do some of the work that needed to be done? And what I'm now going to share is what we've learned over the past several years in trying to create these pillars of efficiency so that we could still be successful and viable in this alternative practice model. I think there are three real pillars to efficiency in practice, one of which is our internal resources. The two biggest cost categories that we have are going to be basically your staffing and your facilities for most people, okay? And then we'll talk about leveraging the external resources and then leveraging technology, all to bring this efficiency in to be able to take and create a practice that is thriving and physicians that are happy and thriving. So the number one thing that we learned in leveraging staff was that everyone has to work at the top of their scope, period, right? And I'll go into some details there. The other is, we want to make full use of facilities. We don't have empty rooms. I mean, Felicia and I, we share a single office. We share the same rooms when we're not there. The other one's using them. Same thing with scribes. I've got where we share all of our staff, where they're busy all of the time. The rooms almost every day in our different clinics are for the most part full. If we have a facility that is not going to be one that we use every day, we try to pay for it on a per diem basis. And we've actually been able to leverage that to create some really nice relationships. The next is you have to have a staffing strategy, and that means you really need to take out a few minutes to analyze the work allocation and your workflow for each person. And you're going to hear this theme over and over, and it's really to take time out to think strategically when it's a repetitive task and not tactically. We're all focused on how can I do this single task the most efficiently. Well, do I need to do the task first? I think that's the first question. Does it require my physical presence to do there? And then, you know, in today's staffing market is very, very tight, at least where we are and what I'm hearing from my colleagues. And so this also actually allows for some variable work hours for the staff, right? And that starts with prudence and hiring. I think all of you would agree with the same lessons that I have learned and that I'd listed here, that it's much easier to take and find people than to get rid of them. I think that whenever we have problem staff, it increases the stress of the office, the workload of everyone, and certainly cost. Many of us that retained all of our staff during COVID realized when we came out of it, we're really happy that we did, because the ramp-up period to get new people, well, first to find them, but the ramp-up period to get new people trained, I mean, that can last a long time, and it's very expensive. And certainly there's some risk, obviously, of wrongful termination, et cetera. We want to clearly define the skill requirements for a particular job, right? So if it's a job that I'm delegating, I want to, one, define what that is that I'm delegating, and two, you want to make sure that you convey those expectations, right? There's a process that's followed, and we have our administrators know this, and I'll get to my number one theme for hiring here in just a second. And you want to make sure that you set them up for success. And I'll give an example, right? I like to watch football, and the National Football League is fantastic as a form of entertainment, sometimes that I share with friends and family, et cetera. Despite my last name, if as much as I want to play in the NFL, I would not be successful. I can watch it on YouTube all I want. I can play as many Madden football games as I want. I can put my last name on the back of a jersey. I get out there, I'm not going to be successful. So don't put people in a position where they're not going to be successful. I think it's the same thing with residents. You know, when they would let a resident go through for a particular specialty, if they're not good at it, they are going to be unhappy. So we want to make sure that we are very clear in what we need and we know ourselves, and we put people in positions where they can be successful. And the other is we all have high performers. Hopefully we have mostly high performers in our organizations. And we don't want to punish those. I mean, you have people that have stuck with you for a long time. They make your practice run. They make your life run. And when you bring in people that are substandard, you're punishing them because they're carrying the brunt of most of that. So when it comes to sort of the staffing, I really think it starts with hiring. And rule number one, and this has actually gone from hiring to some degree in life. When I interview someone, or our administrators know this, and we're going to hire someone and we'll ask them, what's the first rule? It's hell yes or hell no. And that's it. And what I mean by that is when you interview somebody for whatever position, and you say, it's absolutely 100% hell yes, I want that person to work with me every day, and you have a big smile when you leave, that's the person you hire. If they're not that, then they're no. That's it. Either all in or not. And by, I think, not taking and hiring people that you have any questions about has really saved a lot as far as staff headache, your own headache, and all the things we talked about. You can actually extend that to life, you know, and time in general. So next, so we need to work at the top of our scopes. We need to spend our time focusing on patient care. So there are things we do that no one else can do. We're very blessed to have a very special set of skills and intellect that enable us to help folks. I don't have the same level of skill when I'm doing data entry, so I don't do it, right? The other thing is we need to take a little bit of time out to learn to manage, right? So we spend so much time learning how to be good surgeons and good physicians. Like the people that work for us, they deserve, one, for us to know how to manage them, to interact, and that's super important. But it also lets you learn where you can create efficiencies that make their lives easier and make yours. The next is the batch tasks, and I'll go into a little bit more detail. One great example, actually, Bob Glazer was speaking several years ago and visited after. He said the best hires that he has made, non-physician hires, is creating these operator positions to answer the phone and batching the tasks of when people call in, and you're taking away some of the many tasks that your front desk people have and delegating those. And if you can take and have people batch tasks, one, by their work descriptions, but also batch tasks by when they do them. You know, like when a nurse will take and she sends in all the orders and all the prescriptions, like that's protected time. If she has to do that in between phone calls, et cetera, then she's going back and forth, reopening, flipping back and forth the EMR. If she says, hey, I'm just going to have 20 minutes, literally shut the door, and that's what she does, it's so much more efficient. We've started actually giving people work 1 day a week from home to do that, to get them away from the phone, just so they can catch up. And they tell us that they are so much more efficient, and their work proves it, of being able to take specific tasks on those days, batch them together, and you stay in that flow as opposed to having to take and reset every time. And again, you delegate when it's appropriate, not to the point where you don't know what's going on. You need to obviously know what's going on. You need to write these processes where they make sense for quality patient care. And then I think, again, think strategically, and also we need to think humbly, because there are some things that we do that we are not the best at. Like I can answer patient phone calls, but I've got some very caring nurses, and they're much better on the phone than I am, to be honest. I've got my scribe that I use, actually I've had her for 10 years, share with another physician. She was a former teacher. She's got a master's degree in history. Said she was fantastic. We actually don't have to pay her as much as you'd think, but we pay her enough to keep her. But she is much better in writing a narrative with months of training, right, than I would be, or to take the time to. MAs, they don't have to just room patients and take vitals and things. So we have some of our MAs do some things like some instrument maintenance, and they're actually doing some equipment service with regards to a number of different devices. They're doing all the supply management, and those are, of the clinical people, they're probably the people that are paid the least, okay? But a lot of them are really bright people. You know, honestly, I feel like their job and also the front desk jobs are some of the hardest jobs in the clinic, but we try to get them working at the top of their scope. You know, the RNs, LPNs, same thing. Many of you in this group know how to take and leverage them with regards to allergy shots, doing all the phone triage. Unless I'm have the very sensitive conversation with patients regarding biopsy results if they call in and they don't want to wait, et cetera. Like, I'm going to make that call. But most of the phone calls, you know, a well-trained nurse, and we keep the same ones around, they can do a better job and will take more time to do that. And frankly, their time does not cost as much time. They're in the practice expense component. Nurse-only visits for removal of sutures, et cetera, or having them do all the work, and basically we come in and make sure that we've got some face time with the patient, we've addressed any concerns they might have. The odotechs, love the odotechs. I would love to see us expand that program to where we don't have to wait till the fall to get them. The scope of practice issues with regards to audiology are not an issue if you use odotechs. We're actually on a national level right now trying to make it to where they can get paid for the work they're doing. We'll see how that ends up. It'd be great if Medicare will pay for them. It will be a cost savings for us and for them. So we use them. They do the vestibular tests that we have doctorate level audiologists take and do the interpretation. They do all of the hearing aid repair, service, and supply management. The odotechs are great with FaceTime with the patients. And frankly, they're easier to work with a lot of times than the audiologist. Their flexibility and engagement we found to be fantastic. And so I can't say enough good things. We need more. PAs, I mean, Bill Blythe and his wife Mary, they've done podcasts and presentations on how to use PAs appropriately. I can tell you, I use them to see a lot of the global visits when it's appropriate for routine things. They do all of first off, we always have physicians in the clinic when the PAs, APNs, et cetera, are there, always. And if there's any question with the patient, everyone starts with the physician. We don't hesitate to go in. But 80% of the work's already done, as you all know, right? But they take care of a lot of the global visits when it's appropriate to do that. They see the initial ER follow-ups or ER referrals, frankly, and see a lot of things I just don't want to see, you know, and they're happy. They do a great job. Initially, I had a much more limited scope of practice with regards to what we let the PAs do. We do see all the new referrals ourselves when they're referred from other physicians, but that's expanded. And you just learn to trust them as you train them. And I'm super happy that we've instituted those mid-levels. Scribes, again, not a data entry specialist. How many people in the room now use a scribe? Less than I thought, actually. Estheticians, we have a busy cosmetic facial plastics person in our practice. My partner, Dr. Spencer, he's fantastic. He's booked out for 6 months, literally 6 months for facelifts right now. He's very well respected in the community, et cetera, but he's got a couple of estheticians that work over there with him. So for all of my head and neck patients, every patient I do a thyroidectomy on that's not, you know, nursing home patient, et cetera, someone that's very elderly, will, you know, I'll have all of them go back for free, and they get a visit with the esthetician who will do free dermabrasion on them at 6 weeks, and patients are so happy with this, right? Because they're getting some scar management, and they'll have big discussions, and they love talking about their scar and their skin and all the things. Well, I'm not doing that, right? So I'll say, hey, and they're happy that I'm referring to somebody that's so enthusiastic about it. From a business model standpoint, actually, over half of them stick around and continue to see the esthetician, even though that first visit's free, their first treatment, et cetera, and they're a lot happier with their neck scars. I do a lot of Mose reconstruction. They're really happy with a lot of the scars with regards to their flaps. Phone operators, we talked about this, and I think in all of these you have to have really well-defined duties and roles. It creates a lot less tension in the office, but also lets people specialize, just as all of us. The reason we're all very good at certain procedures is because we do a lot of them, and we take that under our umbrella, right? Outside resources. I have no financial interest in any of the things I'm going to talk about. They're just some examples of things we use. We use Fuel, that is one of the sponsors here. They'd not asked me to promote it, but I can tell you that's one way that saves some time. because the check-in, check-out process with regards to the cards they have with the barcodes on, that bypasses my front desk, right? Which is great. So in any event, so outside resources, the services for building and computer systems, not just my time, but my administrator's time, for the most part, if there's something that requires a regular repetitive task, even if it's, okay, they need to change the filters in the HVAC system monthly or quarterly, we set up a system to do that. We have an outside source to do this. The computer systems is the same. All routine maintenance, it's not, oh, let's wait till it breaks and then we have to spend, they have to spend hours figuring it out. I've got to spend time talking to them about their decision. So all of those things, we try to set up everything that's a repetitive task, really be thoughtful and do it once. And a good example of that would be, or an analogy rather, whenever you first went to EMR, most people created templates, right? And you create these templates so that when you dictate a note for a tonsillectomy and you're going to do this however many hundreds of times, you've spent one time putting your template together. Think about templating things where it's appropriate in your office, right? So it saves your time, it saves staff time, and that's essentially, you're getting paid for time by CMS, and as you know, all the private payers are based on CMS reimbursement. Per diem offices, again, that's leveraging outside resources. On the per diem offices, so we have 2 clinics that we own, and we staff all the time, and then we have 2 satellite clinics that we don't. And strategically, where we put those are in the biggest multi-specialty clinics in their respective cities. So literally on Thursdays, I've built this massive endocrine surgery practice. Why? Because I go and I have clinic with the internal medicine group. There's 77 primary care doctors in this one group. I go over there every Thursday. I do FNAs using their ultrasounds, and they see me there, and we have lunch every Thursday that I work, and it's great. But the thing I don't have to do is I don't have to manage their building, and I don't have to manage their staff there, their front office staff. So if I'm not going to take it, it'd be something we use all the time, I farm that out, and that's essentially what you're doing by getting per diem space. When there's a snowstorm, I don't have to worry about what's going on with their parking lot. When their computer system goes in. So if you're not going to use it all the time, I strongly recommend figuring out a way to use it on a per use basis. A lot of the compliance, security reviews, coding reviews, audits, I use SVMIC in Arkansas, that's my practice provider. They have an interest in me doing these things right. Most insurance companies do. They will provide these things if you look and if you ask. We will have them come in and do OSHA and compliance training, audits, same thing. You can have them come and do coding review and audits, or different companies that you can have do that. Quality reporting, like, oh my gosh, that's going to be onerous. Not so much. So Regent does it. They'll take and they'll file for you your ACOs, your CINs. So there's a lot of measures that you do and are being kept track of that we actually in our clinics will react to, make sure we're creating the right improvement, but we don't actually have to go through building those interfaces. Additionally, your local outside resource hospital system, we have a very collegial relationship with the hospital, and even though we're totally self-employed. So they have recruiters that they employ. The hospital system, where I was chief of staff for years, is owned by Community Health Systems. They've got 100 plus hospitals that they have major recruiting resources, major marketing resources. They have physician liaisons that manage their primary care, which is their hospital employed physicians. All of those people, just by asking, by networking with them, they will work for you. Most of them set their own schedule, so they're recruiters, they're marketing people, they're physician liaisons that are directing their referrals from their employed physicians. Like, I know all those people really well, and you'd be surprised with literally a 30-minute phone call that the physician actually wants to spend time with them, and a 30-minute coffee will get done for you. I would say those people work dozens of hours for us for nothing, right? Because what's good for us is good for them. Joint ventures, it doesn't have to be necessarily a competitive environment at the hospital. If you think about an ASC, consider doing a joint venture. Not that I'm promoting the business model, but they're going to go through the processes for you of getting those contracts, or they have them. And so the ramp up for the 12 to 18 months to get those, the actually taking and doing the staffing for that, if you could push that and all the benefits and all the work associated with those administrative tasks onto the hospital, there's a lot of value in doing that. And lastly, I use the hospital system to do creative surgery scheduling, and by that, like pretty much just politely, but demand very politely, 2 rooms and show them that I'm efficient in using them. So as I mentioned, I do a lot of adult surgery, and so most of those cases, they're not going to have, there's a lot of preparatory stuff, especially for when I'm doing sinus or skull-based work, or let's say I'm doing midline surgery, stapes, or the reconstructive and endocrine stuff. Like, it takes some time to get those rooms set up. So I don't have any downtime, and I worked with them to train them. So what will happen is I'll literally close the wound and tell them they can go to the room, in the next room, and it's set. I will batch seeing patients. I come in a little bit early, and it's enabled me to be really efficient surgically, because I'll come in early, I'll see the first group, and then I'll have a pause mid-morning, and I'll go see post-operatively the patients that just operated on's families, and then I'll see the next group that I'm going to operate on, make sure all the questions, they get the time, you carve out the time, but by batching that task and having, flipping rooms in a real safe way, we make sure that the patient's safe, obviously, and the procedure's done before the next one comes in the room. And by the time that I'm done, I've got my work finished with regards to the previous patient, the other one's asleep, right, good to go. So I would advise you to take and spend a little time again using those hospital resources and training those folks. Technology, the last thing that we've used a lot of technology to take, and not just templating things, but this Stratus, that's been really helpful. We have a large population, of Marshallese folks and Hispanic people that are in my area. I really enjoy taking care of those families, and having a virtual interpreter that literally is just, that person is right there on an app. You set it on the table, and they're live, and they're talking to them. That's been really helpful. Preset, again, things that are repetitive, preset text-based reminders or follow-up or reviews. Connect, I know there's been a discussion in the private practice study group recently about that. We've also used a couple of other companies. We'd used Health Loop in the past to do actually post-op follow-up, where there's a dashboard, which is really nice, so my nurse could see all the post-op patients at one time. We would take and set those processes up and just let them roll, Also using the patient to do work too. Not all patients are sophisticated enough technologically to enter, but a lot are. So even if your EMR does not have a good user interface with regards to patients being able to enter data themselves, or you're not using kiosks, et cetera, JotForm is something we use that will build an interface with your EMR. That was really nice. And then, we go through, there's a lot of studies, we all know that, but we go through a lot with patients after a visit, and they don't remember a lot. So we want to make sure that we're really good with their sort of self-study communication. They're going to do it anyway. I'd rather point them to good resources, give them good resources, instead of them using Dr. Google, which really isn't good at referring them to good sources. And then for practice management, you can set up your practice management system to have all these key performance indicators right there in the dashboard. So every time I open up my practice management system with schedule, the 5 top key performance indicators are in my face. So all this stuff's automated. So what have I tried to do? I've tried to move this here, right? So the practice expense, those minutes are paid for less than they pay me for my minutes, right? This cost-based method. I'm willing to pay other people less than they're paying me for the tasks that don't require my physical presence. And frankly, it's been helpful. I'm going to give, there are just a couple of studies with scribes, because I was going to skip through these if not many people use them, but this was an early study basically where, they had a pilot, and this was in Ottawa. Granted, there were no trucks there at the time that the study was done, to my knowledge. So they followed these emergency room physicians around, and what they found out, and this was an initial study. I would say when you get 6 months into a scribe, what I saw was actually an improvement in productivity of about 30%, which is a lot, but that's at 6 months, okay? But it showed basically that the number of patients seen by physician per hour was a 13% increase in an initial study. And you got to realize there's a lot of learning that takes place between you and your scribe, right? So this was an observational study of some med-ped stocks, and it showed basically when they followed them longitudinally that an increase in their RVUs, as you can see, about 10%, the number of patients seen. What's interesting here, and I would agree with this, that patient satisfaction actually I think goes up because you're giving them your attention. They feel like you've spent more time with them because actually your attention to them has increased. And this showed that actually the time spent facing the the patient being faced by the physician increased over 50%. The time looking at the computer decreased by 27%. I don't even bring the computer in the room unless I'm going to take and I'm going to broadcast their CT scan. We've got big monitors in the rooms so that people can see it well, but I'll take and I'll throw my my computer up there, show them a CT scan. But other than that, I don't even bring a computer in the room. The only time I really touch it is when I send an order or a prescription afterwards, and in reviewing their documentation in advance. And then the face-to-face time for these visits, I mean, it went up as well. That's sort of the proportion. So those are all really important patient satisfaction things as well. Last study, the urologists are kind of similar in the breakdown of what they do, obviously surgical versus clinical. And so this is used in scribes after 3 months. It showed their increase in efficiency, how many more patients per session. So it more than justifies the cost of doing this is the point of all of this. And you can see the statistics, and then there's some economic data there at the bottom, which showed an increase in overall revenue, and I would agree with that. The best hire that I've made, hands down, as far as my quality of life. It's so nice when I'm done clinically at 5 o'clock, when I see the last patient, I literally walk out of the room, I close my laptop, and I'm done with that. So the rest of the story, what happened? I went back, so 2016 was the best year I'd had. But to that point, it had been stable for 3 or 4 years regarding net revenue. This is my personal net revenue, not clinic net revenue. So then I looked, and 2017 is a little bit off because it didn't have a full year of this modified schedule. So by increasing his efficiencies for Lance, what happened is this was how revenue as a percentage of 2016. So it was down not quite 10% in 17, about 17% in 18, 25. So what it came out to is by working essentially clinically in this compressed schedule, half time clinically, the rest of the time doing these administrative things that are important to me, is life things that are important to me. I went down 22%. I'm fine with that. I wouldn't have been great going down 50%, but I'm fine getting back half my life for 22%. I'll just tell you that. And so that was my story. So what happened with Felicia? Felicia's happy. Felicia spent lots of time with Evan. I was now in high school. Jimmy, her husband, who is not in our practice, though he's a good friend and we get along great with his group, he's in the only physician, the employed physician role through Mercy system, has quit ENT, sadly. Great guy, but he just got sick. COVID was the final straw with a lot of the constraints he had. He had a very restrictive covenant that unfortunately prevented him from practicing otolaryngology for a couple of years. Hired him in a different role, but not as an ENT. So that's our story, and those are the lessons that we learned in the spirit of OASIS as far as the collaboration and the synergy. I would love to hear from any of you for the efficiencies that you've been able to take and use. Some of these I learned from people in this room that have done a great job. Thank you for your contribution. And I'd love to hear from the audience now. These are my other valuations of time, to reel it back in. That how do I define it? Obviously there's monetarily, but as far as overall happiness, meaning, joy, worth, all the ways that we look at the years we spend, I definitely have made that right. So thank you. Feel free to reach out. There's my cell number, our website, et cetera, So I'm happy to visit with you anytime about this. I think this is a model, actually has some, we talked about women in private practice. I think it's got some implications there, burnout, et cetera. I can tell you that as far as fully utilizing the staff and fully utilizing the practice, you do maximize that. and I'm happy to really get into the weeds with any of you that are interested. Thank you.